Hello everybody. In the coming 50 minutes or so, I will be introducing to you the cardiovascular system with a focus on the cardiac part. This is coming like a continuation of something you have been exposed to in the previous year about the vascular component of the cardiovascular system. So the objectives that we should really be targeting in this coming lecture is to describe the components of the cardiovascular system and its two circuits, the pulmonary and the systemic. We will like this little review. Then describe the heart, its location, topography, blood supply. Again, that will be repeating something you have been exposed to in the gross anatomy lab. And the histological organization of its chambers. Of course, the histology part would be something new to add. Describe also the histological organizations of the three layers of the heart. And then go to the skeleton that is keeping this heart in one piece, the fibrous skeleton of the heart and its structure and function. Then go into the components of the heart valve or valves, then going into the vessels with a quick review of the three layers forming the vessel wall, the three vascular tunics, and how each type of vessels, be it heart, be it arteries, be it veins, how do they differ at different sizes. And then we'll be able to differentiate, if you have given a light micrograph, to be able to differentiate between an artery, a vein, and maybe also a lymphatics. Then we should tackle some concepts, what is called defining the microvascular bed, what is portal circulation. And then, if time permits, we'll look at some histological alterations and atherosclerosis, hypertension, and cardiac ischemia, if time permits, how these three layers can become abnormal in certain circumstances. So, no need to stress the importance of the cardiovascular system. This is actually a system that is very important for all other systems in the body. It is the system that supplies nutrients, disposes of waste, and it's the system that will be able to maintain homeostasis, that is a favorable cellular environment around our organs. So it's a system that should appear very early in embryology during development, and that's the way it is. It's during the third week of organogenesis or embryogenesis that we have the beginnings of the cardiovascular system. And for you to know that it's the heart appears early, functions early. It's the fourth week after fertilization, about day 22, one can hear or begin the beating of the heart. So the heartbeat can begin regular at day 22. The heart is not fully formed yet, of course, but one can hear the beating. So this system that I've been stressing is very important. It is, like any system in the body, is formed of organs. The organs here are the heart and the vessels. It is a system that is formed of vessels and heart, and they are all continuous with one another. It's a completely closed system of networks of tubes that is lined by endothelial cells. So the endothelium is all over the system. It's the lining of the whole system. And the general purpose of this system is to perfuse the capillary beds of all organs in the body with the fresh blood, and this perfusion is done over a really narrow range of hydrostatic pressures. So, and the perfusion also depends on the function of the particular organ, what are the demands of that particular organ, or what are the demands of that particular function. So the structure and function, structure and walls, structure of the wall and the function of the particular part of the cardiovascular system determine the structure. The function determines the structure. In brief, whatever function is needed, the structures will be modulated, and there will be a good correlation between structure and function. That's a very important concept that we should consider while looking at these variations in the structures of the various components of the cardiovascular system. So, as we said, we have a central organ, the pump, the heart. It's a four-chambered organ with two atria, right atrium, left atrium, separated one from another through a wall, the interatrial wall, and two ventricles, the right ventricle and the left ventricle. And again, they are separated by an interventricular wall. So it's a four-chambered with valves allowing one-way passage in the various parts of the heart. So blood will be coming through superior and inferior vena cava and the cardiac venous blood. They will all come to the right atrium. In the right atrium, the blood will be passing through a tricuspid valve, a valve made of three parts, reaching the right ventricle. The blood will be going through the pulmonary trunk or pulmonary artery, through again three semilunar valves to go into the right and left lung. In the right and left lung, the blood going through pulmonary arteries through, but it's the least oxygenated here. It will go to the lungs to get oxygenated and will come back to the heart, to the left atrium, through four pulmonary veins, two from the left side and two from the right side. So here you can see that we have pulmonary arteries. We call arteries anything that take blood away from the heart, veins anything that bring blood towards the heart. So this circulation to the lungs and back to the heart is called pulmonary circulation. This blood that's reaching the left atrium, going to the left ventricle, will be getting out of the left ventricles through the aorta, through this large artery, through the aorta, going to all the rest of the body. This is what we refer to as systemic circulation. So we have two circulations, two circuits, the systemic circulation that will go all over the body and which will come back through veins to the right atrium, and the pulmonary, which will go from the left ventricle, left and right lung, come back to the left atrium. So we have two circuits, systemic and pulmonary circulations. This whole system of vessels and as well as the heart is lined by endothelium, which is a specialized simple squamous epithelium that lines everything: the heart, heart valves, all blood vessels, and even lymphatic vessels. So this is a section actually of a vessel showing the lining epithelium or endothelium towards the lumen, and what is here in blue are the nuclei of the endothelial cells lining the vessel. This is an artery, of course. You can see this very thick elastic lamina that you have been introduced, and some here smooth muscle cells in the media and connective tissue in the adventitia. So this is internal elastic lamina. So this is something that you will see when we go also to the arteries. But the stress here is on the endothelium, which forms a lining of the vessels and the heart. It is like any epithelium. It is underlined by a basal lamina. So these endothelial cells are extremely important. They are not just a static lining. They are very active cells. They have multiple functions. They are highly selective in the exchange of materials with the tissues. They have a role in non-secreting something non-thrombogenic in the surface to control clotting, the heparin, tissue plasminogens, von Wildbrand factor. This is quite important. They control vascular tone by secretion of smooth muscle contractors like endothelin 1 or angiotensin converting enzymes, or also relaxers like nitric oxide, prostacyclin, have roles in inflammation and immune responses through the secretions of different kinds of interleukins and other growth factors. So they are really, and much more functions. So these are some actually of the functions of this lining endothelial cells. So it is believed that endothelial dysfunction is a key to pathologic mechanisms now in COVID-19 as well as in many other inflammatory reactions. So this endothelium forms the inner lining of all vessels, arteries, and veins. We have the large arteries, like the aorta, large elastic arteries, whereby the three layers, the three tunics of the vessels, the intima, the media, and adventitia, they vary. The variation is mostly in the middle layer, which contains the smooth muscle cells and the elastic laminae. For example, the large arteries, the elastic arteries, they have a lot of elastic layers, elastic laminae that are fenestrated. Between these laminae, we have also connective tissue material, especially fibers, collagen type 3 fibers. These arteries, when become middle or muscular arteries or distributing arteries, the amount of elastic fibers will decrease, the amount of smooth muscle cells will increase. And as we go down to smaller and smaller vessels, again, the variation is mostly in the middle layer with less and less elastic fibers and some smooth muscle cells will decrease also in number of layers until we reach the arterioles, from the elastic to the medium-sized arteries, distributing arteries to small arteries to arterioles, where you have one or two layers of smooth muscles around the vessels. As for veins, of course the large veins here they have, in general, again, we have variations in the middle layer. We have much less smooth muscle cells. Sometimes they are longitudinally arranged, sometimes, or form small bundles. We have less and less smooth muscle cells as we go into smaller and smaller veins. So much so until we get to the venules, where we have very few smooth muscle cells, where we start getting something in lieu of the smooth muscle cells, like at the end of the venous, the pericytes. These pluripotential cells that can give rise to different kinds of cells, including they can act as contractor cells, as muscle cells. They are pluripotential cells. So the main difference inside in the intima with respect to the inner layer, to the tunica intima, the veins have valves, especially in the upper and lower extremities. The veins have valves that allow one-way direction of blood flow towards the heart. So then we have the capillaries at the end of the arterioles, and these capillaries will be continuing through the venules, and we have what we call arteriovenous anastomosis. We will be talking maybe more about that later on, towards the middle of the talk. So we have the arterial system that's divided into different arteries of different size, the venous system again, and the capillaries here, which are also of three types, at least three types. Some of them are continuous tubes, some of them are fenestrated, some of them are, if you want, discontinuous or irregular in shape, calling them sometimes sinusoidal. So here the microcirculatory bed or microvascular bed, this is where the arterioles with one or two layers of smooth muscles, and they form precapillary sphincters at the exit of the capillaries. The pericytes are shown here clearly. So these capillaries will communicate with the venules, which have at their beginning also pericytes, then they'll start having the smooth muscle cells. The arterioles here are the vessels of resistance. They have these sphincters that will control the passage of blood into the capillaries to perfuse the tissues, perfuse the organs. They are the vessels of resistance here. So we have to remember this. Remember also the components of this microcirculatory bed of the arterioles, of the metarterioles, of the capillaries, and of the venules. And you can see sometimes direct communications between the arterioles and the venules. They don't have to pass through capillaries. So the microvascular bed or microcirculatory bed consists of arterioles, associated capillary network, and postcapillary venules. Remember this, please. Another concept is portal circulation. It could be a venous or an arterial portal circulation. This is when a vein or an arteriole is interposed between two capillary networks. In case of the liver and pituitary gland, we have what is called the venous portal system. In case of the kidney, we have the arterial portal system. Okay, so the concept is that to have two capillary networks and interpose between them either a vein or an arteriole. So this is a glomerulus portal system, or this is normal network. This is where you have a capillary interposed between an arteriole and a venule. This is the typical arrangement. When you go to the arterial portal system, you go to the kidney, for example, we have a capillary network between the afferent arteriole and the efferent arteriole. So this is called arterial portal system. Or going to the venous system, so you go, for example, in case of the liver or of the hypothesis, in that case, the hypophysis or the liver, we have the capillaries here, especially in the liver, they are sinusoidal, and these two capillaries are interposed between two veins. So this is venous portal system, this is arterial portal system. These concepts, you should understand them really very well. Now moving from generalities into the heart, you know from your previous studies that the heart is situated in the chest. It is covered by a sac, and on top of that sac is called the pericardial sac. We have blood vessels and nerves running on top of the sac, that is the pericardium. And this pericardium, of course, has as a sac is double layered, if you want. It is double layered. This here is the pericardial sac has been cut. You can see directly the heart tissue. You can see that the pericardial sac reaches 1 or 2 centimeters of each of the vessels coming out of the heart here. Whether talking about the aorta or the brachiocephalic or the pulmonary trunk or superior vena cava. And then you can see again this sac here has like little small cavity between it and the heart. This is the pericardial cavity, and it has in general some seromucous fluid that will allow decrease friction, allow movement, free movement of the heart within the sac. You can see that the anterior surface of the heart is formed by mainly the right ventricle. Here is the apex of the heart, and this is the right atrium of the heart. You can see through the lining mesothelium here on top of the heart, which is actually the inner layer of the pericardial sac that is reflected on the heart. You can see the fat, which is part of the epicardium here. And it's all around the blood vessels, the veins and the arteries of the heart. So the heart, which is a pump, a muscular pump, with muscles running in different directions, allowing the free movement of the heart and its beat. You take a small biopsy of that heart, you look at it from inside. This is the endocardium lining the cardiac cavity. You see that there are some protrusions of muscles and tissues into the lumen. We call them trabeculae. Because they are in the heart, we call them trabeculae carni. So deep to this thin layer of endocardium, we have the thickest layer here, the myocardium or the cardiac muscle. Then the outermost is the epicardium here. And that epicardium contains, of course, the mesothelial lining, some fat, and the coronaries in it. So that mesothelium will be an inner reflections of the inner layer of the pericardial sac. So the pericardial sac is here with 2 layers, an outer fibrous layer, an inner serous layer, and its small cavity, and another, if you want, a layer of the pericardial sac, basically the mesothelium part. So between these 2 layers of mesothelium is here and mesothelium is here, we have a cavity called the pericardial cavity. So you see, we call it visceral layer of serous pericardium inside, and this is the pericardial cavity, and the parietal layer of serous pericardium, and the fibrous layer of the pericardium. So if we want to look at it more closely, So the outer layer here, this is the heart, this is the chamber of the heart. It has the endocardial, thin endocardial lining here, then the thick myocardium, then the outer layer, the epicardium, then we have the pericardial cavity of the sac, then the fibrous and another if you want, serous layer of the sac. So this cavity can sometimes get filled with more fluid than needed, and it will hamper the movement of that muscle wall of the heart. So this is a section through the epicardium, which shows again the mesothelial lining, which was a reflection of the inner lining of the sac. This is epithelium, mesoepithelium, some connective tissue deep to it, fibers, cells, connective tissue cells, collagen fibers. And then within these connective tissues of the epicardium, we can have nerve fibers, we can have vessels where we have the coronaries here, and then we have the fat that's accumulating around the heart here. So this is the epicardium, and here is the myocardium. So the epicardium is we have a serous covering forming the visceral layer. It's a simple squamous epithelium, mesothelium supported by connective tissue. Containing within this layer are veins, nerves, ganglia, adipose tissues, arteries. They all accumulate in this layer. So to reach the coronaries here, if you want to reach the coronaries, to manipulate the coronaries, you need to take out the mesothelial lining, some of the connective tissues, to have access to these coronaries, be it the right coronary or the left coronary artery. So you can see clearly they are running in fissures, and fat is covering good part of them. The amount of fat is variable between one heart and the other. And this is to give you an idea about the arrangement of the muscles. They are arranged in the form of spirals around the chambers, and their contraction, you can tell that it will result in blood getting squeezed out of these chambers into the various vessels. This is another view of the cardiac muscle. This is more of a microscopic view. So in your study of muscle tissue, you know that cardiac muscles are mononuclears. They have only one nucleus that is situated centrally within the muscle fiber, and that the muscle fibers or the muscle cells bifurcate. So they bifurcate. They have one nucleus that is central, and they have also the intercalated discs, which when you look with the light microscope, you see them as a dark line only, dark line. So these intercalated discs. They have, if you want, opening of different tubules, junctions, communicating junctions, gap junctions. You find them in the intercalated discs. So again, the cardiac muscle, as you know, has well-arranged fibers. It is formed of sarcomeres that run between a Z disc and a Z disc, and all around that fibers you will see the transverse tubules and the sarcolemma, continuous sarcoplasmic reticulum, and they all communicating. They play an important role in the passage of calcium ions and other ions for the contraction of these muscle fibers. The typical arrangement of a sarcomere is clear, as you knew from previous courses. You see here the central location of the nucleus in these fibers. And not only that, you can see that they have a lot of mitochondria as a source of energy for the good action of cardiac muscles. Another look at the myocardium of these cardiac muscles under the microscope. This is a longitudinal view whereby you see long fibers, and some bifurcations sometimes can show, like here. And this is a cross section of the same muscle. So when blood supply to these muscles becomes hampered, then myocardial infarction, or this is a symptom of ischemic heart become ischemic, not getting enough oxygen, not enough nutrients. So it will lead to death of the cardiomyocytes. Now the second layer, or the third layer, the endocardium, which is the inner layer, it is very much homologous to the intima of blood vessels. It consists of single layer of squamous endothelial cell resting on a basal lamina with subendothelial connective tissue, which plays quite important role here, because within this layer, which contains some elastic fibers, some collagen fibers, some smooth muscle cells, very rare ones, we have what we call the subendocardial layer, which contains the Purkinje fibers, the conducting system of the heart, along with some nerves and veins. So this layer here, this is where the conducting system of the heart lies, and we will come back to it later on. So this is another view of the endocardium, showing us the endothelial lining, the myoelastic layer, connective tissue, then the subendocardial layer, which contained the Purkinje fibers. These large cells with nuclei are the Purkinje. Purkinje fibers are very much like, they are modified muscle fibers. They are much bigger than the muscles. They have a lot of glycogen in them and much fewer fibers, very few fibers. So the glycogen masks almost everything. So holding all these muscles and layers together is the fibrous skeleton of the heart, which is composed of dense connective tissue. So this dense connective tissue of the heart separates between the various, if you want, compartments of the heart, and gives a way where the conducting system can pass. It has all around the opening of the heart, we have the fibrous rings, and between the fibrous rings we have trigones of fibrous tissues, 2 trigones at least, 4 rings, and we have also the arterial and ventricular septa, which are all forming the fibrous skeleton of the heart. This is where the myocardium gets attached. This is where the valves gets attached. This is where that's actually form the skeleton of the heart. Attachment of valves, atria, etc., holding the heart in one piece. Okay, so the interventricular septum, interarterial septum again. So this is another view of the fibrous skeleton, the heart using to stain the HND, hematoxin A in the routine stain, or using a special stain for muscle, that is a trichrome stain, which is Mallory or any other. Here it is Mallory, where the muscle looks red when the connective tissue uh, uh, look blue. In general, connective tissue blue. Okay, this is here the valve of the heart, small valve, which is basically connective tissue and endothelial. So this is horizontal section of the heart. If you want to look which one is left ventricle, which one is right ventricle, you can tell, and they are not labeled, you can tell from the thickness of the layers. The thickest layer of the heart is the left atrium, and this is the right ventricle, left ventricle, this is the right ventricle. Attached to these ventricles are the valves through cordi tendini, through special cords, and through muscles that we call them papillary muscles. So we have the muscles, continuation of those muscles on the ventricles. Then we have cordi tendini, small cords that will be holding the valves of the heart. So epicardium, myocardium, endocardium here. Another look at the valves in the heart. This is the myocardium. This is part of the epicardium and connective tissue layer. This is where the coronary artery is in the epicardium. And this is the wall of the atrium. And between the atrium and the ventricle, attached to the fibrous skeleton here is the valve. This is a valve. Here, this is the case of the mitral valve. This is the atrial part. And here is the ventral part. So more closely, if you want to look more closely at the valves, so this is the outflow surface and this is the inflow surface. So we have three layers. The fibrosa layer, they are all lined by endothelium, by the way, and the innermost the content here is connective tissue. Okay, so these three layers, we have the layer called ventricularis or atrialis, and this layer is rich in elastin at the outflow surface, or the inflow surface, and this elastin here facilitates the rapid recoil of the valve. They are all lined by endothelium. The inner lining here is the spongiosum, the central loose core of connective tissue made of collagen and elastic fibers, and whose major role is to dampen the vibrations of the valve while closing, and the fibrosa, which is, as the name implies, dense, irregular connective tissue at the outflow surface, and this is an extension of the fibrous skeleton. Again, it's lined by endothelium. So here, kindly note that the cordi tendini in the atrioventricular valves are extension of the fibrosa. This is a question about the papillary muscles of the heart, about their function. I'm sure you will be able to answer this easily after this small introduction that we had. We pass next to the conducting system of the heart. The conducting system of the electric conducting system, if you want. And this is distributed at the junction of the superior vena cava and the right atrium. It's called the sinoatrial node. This is the pacemaker of the heart, and it's actually not only that, it is the part of the conducting system that has the fastest rate of depolarization. It has between 60 and 100 beats per minute. And this depolarization, of course, passes through the atrial wall here, to reach the atrioventricular node, which has a rate of about 50 beats per minute. Then from this node we'll go down the bundle of His, the atrioventricular bundle of His, and then as it reaches close to the apex part, it will form the Purkinje fibers on either side of the two ventricles. So Purkinje fibers, if the SA is blocked or the AV blocked, the Purkinje fibers have 30 to 40 beats per minute. So when someone is ablating this node, then will pass from the 60, 100 to 50 to 30. And then if you ablate both, we will be passing to 30 to 40 beats per minute. So all this conduction is actually regulated by also the sympathetic and parasympathetic system. The parasympathetic, which will decelerate or decrease the rate of heartbeats, while the sympathetic will increase the heartbeats per minute. We have also some substances that are secreted by the heart, and like atrionatriuretic hormone and other substances. Again, the control of heartbeat can come also through substances like calcium, thyroid hormones, caffeine, epinephrine, norepinephrine. They all can play a role in controlling the or manipulating the heartbeat. So now, so that's in brief the three major components. The SA node, as I said, is the pacemaker of the heart. It has the most rapid rhythmic activity. Its location is at the between the superior vena cava and the right atrium. It's formed of cells called the nodal cells, which are modified cardiac muscle cells. In general, they are much smaller than the cardiac muscle cells. This is in opposition to the Purkinje fiber, the Purkinje cells, which are much bigger. So they are containing within them fewer myofibrils. And nodal cells are concentrically arranged around a large nodal artery. This is how we look at them in histology. This is we try to find a concentric arrangement of cells with an artery in between to recognize the place of the node, SA node or AV node even. So again, it is located, this is important, the location is beneath the septal wall of the right atrium. This is important. If you want to ablate it, you have to know where to find it. So it's located beneath the septal wall of the right atrium, and you can find also arterioles around it and some adipose connective tissue. The bundle of His is made of Purkinje fibers. These cells are much larger than the cardiac cells. They penetrate the fibrous skeleton and they divide into right and left bundles of fibers. Okay, now a few words about the circulatory system, the arterial system, the venous system. Lymphatics, you have it separately. The gross anatomy course had really worked on the different components of these systems, and the histology in the CMM course has worked a lot on the different vessels component. Anyway, this is an overview to tell you that blood vessels are composed of tunics or layers or coats. The one towards the lumen is the intima, the one in the middle is the media. This is where most of the changes occur between different vessels of different sizes and of different types. And this is the outermost layer, the tunica adventitia. This is a light microscopic view where if we study it together, you can see here, this is a vessel that is well rounded with a corrugated lumen with layers here of nuclei of smooth muscle cells and layers, concentric layers of elastic tissue. So the intima is here, here is the media, and this is the adventitia, which is mostly connective tissue, where the collagen fiber is mostly type 1 as compared to type 3 in the media. So this artery remains patent, the lumen is patent, although it is corrugated because of the elastic tissues that have recoiled during preparation. We look at this one, this is a collapsed vein. This is a vein that has collapsed, doesn't have enough elastic layers to stay open like the artery, and you can see that the media is much thinner, fewer muscle layers, much less or very little elastic laminae, while you have a larger adventitia. Adventitia in veins is much larger than adventitia in corresponding arteries. So this is an example, a comparative example to show you both. And here you can see, I'm sure, the cross-section of nerve fibers and of fat tissues all around the neurovascular bundle. So again, in this quick review, this is the heart, major vessels, elastic arteries with 3 layers, 3 tunicas, very obvious. Tunica intima, and tunica media, and tunica adventitia. We go to the next size, the muscular layer or distributing arteries, muscular arteries, distributing arteries, where we have a lot of smooth muscle cells in the media. The adventitia is of course less, but it fuses with the surrounding tissues, and the intima is very much the same, except go to the arterial or small arteries. Here most of the adventitia is gone, and the middle layer is 1-2 layers of smooth muscle, and of course with the intima and endothelial. This is continuous with the capillaries, which are of at least 3 types, as I mentioned, and then from capillaries to post-capillary venules. Here pericytes will appear instead of smooth muscle cells. This is where we have the microcirculatory bed, and then the venules. So the exchange of material between the blood and the tissues happens basically at the capillary level and at the venule level. The passage of blood cells into the tissues is basically at the venules level. In the venules, I can see the media, of course, very tiny. It increases in size in here, and it increases even more here. The difference here in the intima between the artery and the veins is that the intima forms the valves. We have valves, especially in the upper lower extremities, and to help in the propulsion of blood towards the heart. So this is a comparative table about the different vessels, different sizes. If you care for it, it's better to know, to study this table that will give you a summary of what we had last year in the CMM course. It's in one slide. These are the capillaries I was alluding to. This is the continuous capillary with continuous endothelium with junctions between the endothelial cells. and the continuous basal lamina on the outside with pericytes within the basal lamina. These multipotential cells can be working like muscle cells, can give rise to endothelial cells, to any other cells. And the other type is the fenestrated capillary, where you see fenestrations within the endothelium. And however, you're having pericytes around, and we have the basal lamina surrounding all these vessels. The third type is the discontinuous capillaries, or sometimes sinusoidal capillaries. You have much more irregular shapes and fenestrations, and we have a discontinuous basal lamina. So this is important to know. This slide is quite important to understand. This is a electron micrograph of a continuous capillary showing the tight junctions between one cell, endothelial cell, and another, with the pericyte and the basal lamina on the outside. This is compared to this one, where you have fenestrations within the endothelium. See? And these fenestrations sometimes have like doors, flaps, or sometimes without doors and flaps. So the gaps could be covered by small flaps, or they could be directly open. Some people divide these fenestrated capillaries into two types, but it's actually one type. Vasa vasorum is a concept that you should understand. Big vessels have vessels of their own, especially they are thick, so the blood circulating in the inside the lumen of the vessel cannot reach all the layers, so we resort to vessels especially coming to supply the outer layers of these vessels, be it arteries or veins or whatever. So this is a muscular artery, just to give you an example. This is the intima, this is the media, and this is the adventitia. And this is a vessel coming to the vessel, vasa vasorum, supplying the adventitia, going into the media. In veins, the arteries penetrate more inside the middle layer. In arteries, they stay on the surface of the middle layer. Normally, they don't go deep into the middle layers. Vasa vasorum. So one final thing about endothelial cells and all this, they participate in the structural functional integrity of the vascular wall. Why I put it separate? To say just endothelial cells are not static cells. They are very active cells, and many of the diseases, cardiovascular diseases, start within the endothelial cells. Word about pericytes, which you have encountered in the capillaries and the postcapillary venules. They are of mesenchymal origin. They have prolonged processes. They surround the endothelial cells, and they are enclosed within the basal lamina, as we have seen before. They have great potential of transformation into other cells for repair of vessels or anything, and they have myosin acting tropomyosin in them, so they can function as contractile cells. Arteries in general sometimes have something called bodies, some aggregations of cells at certain sites. One major example that you have encountered in gross anatomy was the carotid bodies at the here at the bifurcation of the internal and external carotid. And we have other ones like at the arch of the aorta. We have also another body. So these are mostly working in the control of blood components and of blood pressures. This is another real view of the carotid bodies. Here is the carotid sinus and the internal carotid artery at the beginning. So This is atherosclerosis. This is a small paragraph to tell you how the plaques within the wall of the arteries can form and the deposition of connective tissues and other substances narrowing down the lumen. So lipids will deposit and they will lead to thickening and toughening of the walls, so you will not have a smooth circulation in the walls. Another thing, another view of the same thing, you see here, this is in the coronary artery, and you can see the accumulation within the vessel wall of different types of inflammatory cells and connective tissues. So please read about this in your book. There are good examples to tell you about pathologies that can happen in the cardiovascular system, and thank you for your listening.